Good evening, everyone. Thanks for joining us for our presentation tonight. I'll be talking about enuresis, which is basically day and nighttime wetting. As we go through the presentation, please let me know at the end if there's any questions. So we're just going to start off with talking about some of the anatomy and then the bladder and bowel dysfunction. What is nocturnal enuresis? Basically, that's bedwetting, constipation, and then just the reference list. So with regards to the anatomy, we, of course, mostly are going to be looking at the urinary system, which its function is to filter the blood and create urine. It involves the kidneys, the renal pelvis, the ureters, the bladder, and the urethra. Micturition cycle, it's basically the cycle described to create the urine as well as excrete the urine. So making it and getting rid of it. It's under nerve control and it's complex and can require quite a lot of understanding and compliance from the child. So more information with regards to the kidneys. They're a pair of organs located below the ribs toward the middle of the back. The urea is filtered from the blood, and so it's basically all the waste products and water make up the urine. Its job is to remove those waste products from our body, balance the body's fluids, release hormones to regulate blood pressure, and control the production of red blood cells. The ureters, which are basically the tubes that connect to the bladder, they carry the urine from the kidneys to the bladder. The muscles in their walls continually tighten and relax, forcing the urine downward away from the kidneys. Every 10 to 15 seconds, small amounts are emptied into the bladder. And if urine backs up, that's where you can start to get a kidney infection or further issues. If we look further at the bladder, it's a triangle-shaped hollow organ. In the lower abdomen, it's the storage organ for urine. So those ureters are constantly dropping the urine into the bladder and it stores up. It's held in place by ligaments, and there is the sphincter at the bottom to prevent the leakage of urine. When the walls relax and expand to store the urine, and then they contract and flatten to empty it through the urethra, which is the tube coming out that empties the urine. Micturition, which is what I explained, is where the urine is created and expelled from the body to eliminate the waste products. It consists of kidneys, ureters, the bladder, and the urethra. The kidney plays the major role in the process of urine formation and its excretion. And as the bladder becomes full, the receptors increase their firing rates, and this increases the urge for us to urinate and causes the micturition reflex. It can also be involuntary urination, and then the voiding phase is when the urine is expelled. So what happens when we need to expel or urinate? Your bladder gets filled with urine, triggers the nerves around it, and you get that urge. You can either choose to urinate or withhold. But if you choose to urinate, the brain signals the bladder to contract. It sends another signal to the central nervous system, which sends a signal which basically excites the bladder and gets it to contract. And then the sphincter opens and the urine is eliminated. So the reason why we talk about all these kind of anatomical things is just to have a better understanding of what's going on with our little people's bodies and how complicated the processes can be, and how much understanding needs to occur in order to figure out what is the cause and what is the problem. So another system that's really important is our digestive system. We'll soon talk about the relationship between the bladder and the bowel. So the digestive system is for digestion, absorption, excretion, and protection. Some of the similar functions to the urinary system, anything to get rid of the waste products in our bodies. We've also got the pelvic floor, which, as you can see in the picture, kind of encapsulates, kind of goes around the bladder, the bowel, and the other important organs. It's bowl-shaped, and it's for continence, so making sure that we are not leaking either poos or wees during the day. It allows us to empty both the bladder and the bowel. It supports the organs around it, an important part of the core. So how often should our little ones, or even us, be going to the bathroom? With our bowel, it starts getting less and less as our children get older. Of course, when they're little babies, there's lots of pooing happening, but it should be similar to an adult by 4 years old. They say that you should be going to the toilet daily for a healthy bowel regime. And for our bladder, we should be going around 4 to 7 times a day. By 5 years old, a child should be continent both day and night, and increasing that bladder volume as they get bigger. How you can work it out is normal bladder capacity is their age plus 1 times 30 mils. And there's just some other norms. So children who have wet the bed have decreased output, basically volumes, without there being any kind of anatomical difference to a child of a similar age. So norms for bladder control, children should start to get that urge to wee between the ages of 1 and 2. Normal bladder development is evident by the age of 5, but 17 to 22% of children have symptoms that persist beyond age 5. And as mentioned before, it's not because there's often a like anatomical difference, it's mostly functional. So bladder and bowel dysfunction, this is just a quick little picture to show how important the relationship is between the bladder and the bowel. So if you have a big lump of poop waiting to be excreted and you've got a full bladder, that poo is going to push on that bladder and you're going to get those little wet pants or little bits of wee. It's mostly not a full wee, but you do get that leakage because it's that compression on the bladder, and it results in a decreased urge to wee, having those not emptying fully and it not fully coming out. So constipated children are 6 to 8 times more likely to have lower urinary tract problems than those that aren't constipated. It's called bladder and bowel dysfunction. So most of the time there's a significant relationship between the two. It's because they share similar nerves, neurocenters, and they come from a similar embryological origin. So they can kind of get into the cycle. So children that hold their bladders, they get reduced sensation to empty their bladder, so they don't have that urge as much, resulting in the constipation or bowel incontinence, because they have those withholding behaviors. So they don't have the sensory experience that they normally would have. It's more everything storage, and they don't get that sensation to wee or poo. It can cause physical and psychosocial burdens for families, and it's commonly associated with recurrent UTIs, especially in girls, that can lead to after effects and further problems. It can negatively affect a child's quality of life and self-esteem, and it's really important to get these kiddies in as quick as possible. The longer you leave it, the more difficult it is to get it right. So children and adolescents that have these lower urinary tract dysfunctions, they can tend to have more UTIs, renal scarring, anxiety, depression, aggressiveness, and social isolation may be expressed because of this constant discomfort and loss of urge and, wetting your pants. It's unknown what is cause and consequence. Is the psychological factor causing the wetting, or is the wetting causing the psychological factor? And 29% diagnosed have associated mental illness, primarily ADHD, and there's an increased risk of being bullied because of these situations that are happening quite often at school most of the time. This is just a simple questionnaire that we give our parents just to understand what is going on when they are wetting themselves. How often are they going to the toilets? How often are they doing bowel motions? Are they doing a full wee, or is it just little bits of wee that are coming out? Is it hurting when they wee? And so on, just to kind of get an idea of, is there an issue here? Do we need to intervene? Do they need to go see the pediatrician to discuss kind of like what's going on with their bodies? Is there any underlying factors, and what's causing this? So there's a few types of these dysfunctions that can occur and can cause wetting during the day. You can have an overactive bladder. So you've got that urgency to constantly go to the toilet. You've got kids that try stop themselves from weeing. So they're not going to wee so many times a day. You're seeing those withholding maneuvers, so them gripping their private parts, squeezing, doing whatever they can not to go to the toilet. Happens very often at toilet training because they're learning that suddenly they can't go in a pull-up. Most of the time they're having to go in the toilet. And then, of course, because of you having these withholding behaviors, a lot of the time it's associated with constipation. And we see good improvement through timing their wees and making sure that they are going every 3 hours. You have dysfunctional voiding, which basically children who are constantly trying to contract that sphincter. Remember I said at the end, at the bottom of the urinary system, when the bladder needs to open and kind of empty, they're constantly contracting that. So you've got this open and close. It's not full open, full empty. While they're trying to empty, you've got this close, open, close, open. So staccato basically means that in the toilet, you'll literally hear it going, you know, some come out, stop, some come out, stop. Is associated also with the constipation or bowel incontinence, because often at the time they are constipated and they needing to fully empty their bowel system, but they are only emptying a little bit at a time. Constipation management and bladder retraining shows good results for this. Then you've got an underactive bladder, children that are kind of going for a wee less than 3 times a day. Their muscles surrounding their bladder is often abnormal. They tend to strain while doing their wees. And they can also just go for a bowel program recommended and urotherapy, which will be just discussed for, in a little bit. Then you've got giggle incontinence, which you often see with girls. Somebody tells a funny joke and everyone starts getting the giggles and suddenly somebody wets their pants. So it's to do with their nervous system. So it's not really functional. That can be taught. But there are things that can make it worse. So bladder irritants, those are your fizzy drinks, all those kind of things that can irritate their bladder that you can avoid in order to stop these from happening. And once again, constipation management, making sure that bowel system is fully empty to not aggravate that bladder anymore. And you can also teach them to engage their pelvic floor before laughing. So trying to get, even though their belly laughs, trying to control their pelvic floor to help with that. And you can look further into the pelvic floor, which can be done with a pelvic floor physiotherapist. Then you've got vaginal reflux, often with overweight girls, when the urine dribbles from the vagina when they're standing up because of that pressure that's been placed on that pelvic floor. And mostly due to decreased core control. And then you've got extraordinary daytime and urinary frequency. You're seeing an increase in those daytime wees. It's often associated with anxiety and stressful events. So I know a lot of people say, I'm going to do my nervous wee. And you're getting a lot of small wees, more than 8 times a day, but they're not ever fully emptying. And it's more common in boys. So what happens when a child chronically holds their wee in? So they get this urge to wee, that bladder neck is opening up. They say, no, don't want the wee, and they squeeze that sphincter again to close up the bladder emptying. Send up a message via the nervous system to say, no, don't contract the bladder, I'm not going to wee. And that in turn creates the resistance that strains the bladder because it's needing to empty, because you can imagine all that weight is needing to be kind of emptied out. And that's a repeated resistance of that bladder muscle saying, no, you can't contract, you can't empty, makes it thicker and stronger. Like if anybody that kind of goes to a gym and trains their muscle is going to get thicker and stronger. So then the bladder ends up later on trying to empty, but that sphincter tries to hold it in because that's its learned mechanism. And then so that sphincter always starts stronger. And then you've got that repeated holding over months or even years. And then the bladder wall becomes thicker and more muscular. So it's just kind of getting worse and worse. That bladder capacity therefore decreases because the bladder isn't able to stretch anymore as much as it should. It kind of remains small and tight. And the bladder contracts more forcefully because it's strong. So you get earlier signals that you're needing to empty. You often have that forceful contraction when it's trying to empty, and then the bladder gets so strong and irritable, it empties without any input from the child and the sphincter can't close it. So it's such a force driving down that it often can cause children to therefore become incontinent because it can't just remain in the bladder. So urotherapy, behavioral therapy works really well. We'll talk about behavioral management in a bit. Education is so important so that the children know what is actually going on with their bodies and what is the implication of them holding on to their wee, what's happening to them, what could be the cause. Having them go to wee every 3 hours or when having the urge, or anytime you see the child withholding postures, doing that, grabbing their private parts, crossing their legs, walking on tiptoes, any of those, you want to encourage the child to go to the toilet and wee. As I mentioned in my potty training presentation, you often don't want to give the child the option of going to wee, rather just saying, hey, we're going to go to the toilet, and encouraging them to do so. You want to make sure that they have enough water, because if a child is not consuming enough water, you've got really concentrated urine that's sitting at their bladder that can irritate their bladder. So a lot of people think, well, if I limit how much fluid they have during the day, then at least they won't leak during the day. It's actually often the opposite effect, because it's making that concentrated urine that's irritating that bladder, and therefore you're getting those leaks happening. Other bladder irritants that I spoke, you wanted to avoid, like fizzy drinks and those kind of things, especially at nighttime. And very important to see the position they're on in their with their toilet. Medications, which of course can be discussed with your pediatrician or your medical professional. And then other ideas, there's a watch that's called a wobble watch that can let the child, you can set the times on it. And if your child's at school, the alarm will go off and the child will be prompted to go and wee. And of course, this is really important to get the teacher involved too. So you don't have the child going, oh, don't worry, I'm not going to do it now, and turn it off, but rather the teacher knows and can encourage the child to go to the toilet. Another way of getting the child to drink enough water, this is of course an adult example, but you can either buy these online, or I don't know if anyone locally sells them, or you can make your own with just a Sharpie pen on their water bottle to show them how much they should be drinking at each time, to make sure that they're having the correct volume of water during the day. It also will decrease the amount they need before bed. So often kids who haven't drunk enough during the day will be the ones just before bed going, Mommy, I'm thirsty, because they know that their body needs it. So we're going to go on to wetting the bed. So all of those, yes, they can affect wetting the bed at night, but this specifically is where we're going to be talking about what would cause wetting at night. So way more common in boys, 2-to-1 ratio. And the research shows us that 15% of children wet the bed at 5 years of age, with 80% of those diagnosed with primary enuresis, which we'll discuss primary and secondary in a moment. So 15% at 5 years old, 13% at 6 years old, 10% at 7 years old, 7% at 8 years old, 5% at 10 years old, and 2 to 3% between the ages of 12 to 14 years old. And then 1 to 2% at more than 15 years old. So you can see it's a really common occurrence. And it's also, it can cause, of course, lots of issues if not sorted out sooner than later. they do say that it resolves spontaneously at a rate of 15% per year. So 20% of children with bedwetting will also experience the daytime incontinence or any of those lower urinary tract symptoms that I spoke about. 50% of children with bedwetting also experience poo leaks because, as we said, that bladder and bowel are so well connected that any constipation will cause other issues with the bladder. So risk factors for bedwetting, being younger in age, of course, closer to the potty training age, where you're still working out what's going on with your body and how it works. As we said, being male, having history of urinary tract infections because you've already got that irritated bladder. A family history, there is a genetic link to bedwetting. Obesity being because of a weak pelvic floor or too tight pelvic floor, low core strength, and also the weight putting pressure on the bladder. Other conditions are chronic kidney disease, diabetes, anorexia, hypothyroidism, and a few other diseases. So if we talk about primary versus secondary nocturnal enuresis, so primary bedwetting refers to the children who have never achieved 6 months of dry nights. So since the time that they were potty trained, they've had to be in pull-ups from that point. And then you've got secondary nocturnal enuresis, where children had previously been 6 months of dryness, but might have relapsed. So these are more likely to occur with changes in school, new baby coming into the picture, problems with mom and dad's marriage, any kind of big change in their life could cause it. And there also might be an underlying medical or behavioral condition. So a recent diagnosis of constipation or something like that. And then you've got monosymptomatic and non-monosymptomatic. So monosymptomatic, the only symptom is bedwetting, and non-mono is when there's other symptoms of, that urgency to wee, the frequency of wee, dribbling wee, and that incontinence and holding maneuvers. So causes of primary wetting. So these are some of the examples. So sleep disturbances, overactivity of that muscle of the bladder, but we'll discuss these further now. So I know all these words are really big and very medical, but nocturnal polyuria just means an increased amount or volume of urine while they're sleeping, so at night. This can be that they're consuming too many fluids before bedtime, or the reduced production of ADH, which is your antidiuretic hormone. So when you're sleeping at night, your body produces this to tell your bladder and your body that it does not need to produce urine or excrete urine because you're sleeping. And it's really important hormone for the body to kind of produce in order to avoid this bedwetting happening. It also, as I said, tells the kidneys that they need to make less urine while sleeping. Children who wet the bed may not only produce more urine at night, they also might have a smaller capacity for that urine storage. So as soon as that bladder is full, then it needs to empty somehow when more urine is made. So there's some thoughts on sleep and bedwetting. Children who wet the bed struggle to arouse from sleep when they have the urge to wee. There's conflicting research because a lot of people think that children who wet the bed are deep sleepers, but it's believed that the deep sleepers don't wake up from the sensation, but then the light sleepers don't get enough sleep for that production of that hormone. So both light and deep sleepers can wet the bed. It's not necessarily an indication that your child is a light or deep sleeper. Causes of secondary bedwetting. As I said, this is when there's other things going on. So diabetes, constipation, new baby, new school, anything's kind of psychological as well. So this is just a table to show comorbidities and their relationship to wetting. As you can see, as mentioned, constipation is the biggest associated relationship to enuresis. With urinary tract infections, we'll speak further about sleep apnea and the importance of their adenoids, and how snoring can affect them. And then also, of course, if you have an overactive bladder. And then, as we mentioned before, ADHD is very commonly linked to enuresis. So Dr. Hodges is, as previously mentioned in my other presentations, the guru in bowel and bladder, and he has some truths that I thought would be interesting to share. So the truth that people think, oh, don't worry, they'll just outgrow it. It'll just go away on its own. There's 70% odds that a bedwetting 9-year-old will still be wetting the bed at 19, because this is functional and it's learned, and there's other factors influencing it. They aren't just all physiological. So basically their body is not to blame. It's sometimes other things going on, which just means that it won't just correct itself. 32% of bedwetting teens also have daytime accidents. Those could be small or big during the school day or even at home. And it's also less likely to resolve if the child is wetting the bed nightly and also experiencing that daytime incontinence. The truth of bedwetting is caused by chronic constipation, when the poop piles up and stretches the rectum, which presses against and aggravates the bladder. When constipation resolves and the rectum shrinks back to size, research shows bedwetting stops, because often it is that bowel is just aggravating that bladder. Bedwetting should be treated around the age of 4. So a lot of people wait until their child is closer to the age of 10, when it's becoming too much of an issue during sleepovers, or the child is becoming really aware of it. So waiting until the age 7 does not serve the child. The longer the rectum remains clogged and stretched, the more difficult the fix, as well as the sooner you correct the things that are wrong, the better. As you can tell, as the child grows bigger, that bladder is of course increasing that capacity, and it could just get worse. The impact of wetting the bed: you get poor self-image, diminished achievements in school, and increase in time spent by families compensating both financially and personally for the symptoms. And then, as mentioned, ADHD is strongly associated. So treatment: how do we treat this bedwetting? So first of all, if there is a constipation issue going on, highly recommended to go to your pediatrician and your care provider in order to get a diagnosis or some sort of plan with regards to the medical treatments. And then, of course, coming to me or another provider in order to get treatment for how functionally you can help them. Education is so important, so that children know what is happening with their body and why this is occurring. Urotherapy we spoke about earlier, and as I mentioned, pharmacological therapy, which can be discussed with your healthcare provider. And then snoring and enlarged tonsils or adenoids can signal sleep apnea, and they've shown that a correction of any of these obstructions can improve or cure bedwetting. So another thing to look at. So this is what we'll be doing during my sessions when I have a child with bedwetting issues. We do a track of bladder and bowels. So I've got a chart that I get my parents to fill in with how often a child is going to poo during the day, how often they're weeing during the day, how much fluid they're having, how many fruits and vegetables they have, and kind of what their input is and their outputs. We look at, are they consuming any bladder irritants that could be causing this, especially just before bed. I'm checking, are they having enough wheeze during the day, to make sure that they are emptying their bladder fully during the day so that there isn't anything left in the bladder at night. Avoiding fluids 2 hours before bed. I know this is really hard to do, especially at dinner time with your child wanting to have a drink, but trying to kind of start limiting that every night so that eventually you can stop that. And then always making sure that they're weeing as soon as they're waking up, even if their pull-ups wet, or if they say they don't need the toilet, encouraging them to get into that behavioral kind of way that as soon as you wake up in the in the morning you have to go wee. One thing also is doing a double void at night, so a double wee. So before you start their bedtime routine, you get them to wee, and then just before they're about to like go to sleep and start winding down, you get them to do a second wee, which really helps. Getting boys to sit to wee. We know that standing does not allow a boy to relax his pelvic floor. So it's really important that he's sitting down and able to relax in order to get that body in the correct position to allow for full emptying. We look at breathing, your pelvic floor and core exercises to make sure that core is strong enough, the pelvic floor is strong to help with that continence and hold those organs in place, as well as breathing just for relaxation and making sure we're getting that full empty. And then something that we'll do is Dawn's dry night training. So basically it tracks, we'll give the parents a specific chart for bedwetting, and they will track for us. It does take a bit of effort from the parents. So basically every hour for the first 4 hours, the child has gone to sleep. The parent will need to go in, check, has the child wet themselves? And if they have wet themselves, of course, change them. And then the 2 hours before they wake up, checking them as well to make sure, like, have they wet themselves and what is the situation? This just allows us to see what the pattern is of them wetting themselves and be able to preempt that. So often you'll find that a child, if they're doing it in the evening, will be wetting themselves around 9:30, 10 o'clock every single night. So at 9 o'clock, going in and kind of encouraging them, or whether they waking them up and encouraging them to go and wee to avoid that wetting. And you can start weaning that off. So that's Dawn's dry night training, which has great results and can be really, really quick. If the child catches on to it, it can be a nice quick fix, or it can take longer for children that, of course, have other things going on like constipation or something else. So other recommendations are that always leaving clean PJs next to the bed, so the bigger kids are allowed to kind of change themselves. The thing that really works well is kind of having a waterproof sheet, having a fitted sheet, having waterproof sheets and a fitted sheet, so that you have quick nighttime changes for a child that's wet the bed, that you don't have to do this whole wake up and trying to change the bedding, just strip it off, throw it into the laundry and worry about it the next day. And then there's something lovely called pajamas. People in the US have created pajamas that have built-in reusable underwear, basically. So it's like a normal pajama pants, but it's just got built-in underwear that is really nice, especially if they're going away on a sleepover, that it's really discreet. It's not them having to go hide in the bathroom and quickly put the pull-up on, and in the morning quickly like throw it away before anyone can see it. And what is also nice about this is often our disposable pull-ups have really good absorbency, and these pajamas allow the child to still feel when they're getting wet, which is of course what we want, because we want them to be prompted to wee. So really good and useful. I think there are, so pajamas is the name of one company. There are quite a few with the same kind of idea. And then just a quick little talk about constipation, because I've spoken about how important it is because of how it can irritate the bladder and have its influence on the bladder. So constipation, between 10 and 20% of children are constipated. It's happening way more than we think. And most children don't realize that they should be pooing every single day. And most parents, as a child gets older, don't feel like they need to check in. So it's a more common problem than we think. Often happens between the ages of 2 and 4. Of course, this is when potty training kind of starts and they're still learning. Functional constipation causes 95% of constipation in children. This is something where there's nothing wrong with their body. It's just that they have learned to withhold, and it's caused issues with their bowel system. And then the other ones, there's a few listed there. That's the other 5%. So yes. Functional constipation is, as we said, associated with lower urinary tract symptoms, between 30 and 50%, and fecal incontinence, 2.9%. Causes can be a bunch of different causes. They can, you know, be withholding because they've done a really like hard poo that's really hurt them. Maybe they've got a bit of an anal fissure, which caused some bleeding because it was so sore and hard. There can be a change in routine. So that could be that they've changed this school, or suddenly they were pooing every morning, but now they have to get to school earlier. So they're not able to sit on the toilets. Do they know where the toilets are when they go out? Because if they don't, they might withhold because they don't want to go because they don't know where it is. Illness can cause it, and there's a genetic link still being investigated. How is functional constipation caused in children? So you get a child who gets dehydrated or says they don't want to poo. The poo stays in their rectum for a longer period of time. And then the more the poo stays in their rectum, the more the body absorbs the fluid, and the poo just gets harder and harder and harder. And then when the child eventually decides to poo, it's hard and it hurts and can cause those anal fissures, which I said is just some blood. And then the next time they need to go, they remember that unpleasant experience and decide to hold it in rather. So that poo keeps on building up in the rectum, which gets larger and larger and larger. And that organ, which was a sensory organ, the rectum is a sensory organ to let the body know it needs to, when it's full, it needs to be emptied. It starts becoming a storage organ. So the child does not realize they need to poo anymore, and often will only feel it later on when they start getting a sore tummy. And this just causes the cycle to continue and makes the problem worse each time. So what to look out for that your child might be constipated: rabbit dropping, licking poos, skid marks on their pants, an itchy bum, tummy aches, UTIs, using the need to use too much toilet paper, very wide poos, any poos that kind of block the toilets, very loose poo, needing to push really hard in order to get a poo out, having bedwetting and accidents, toilet training issues. So just to show you, you're looking for a type 4 poo. That's the ideal poo that a child should be doing. And it's really important that you teach children to check their poo so that they can let you know if there's any problems that occur. These are just the references for the presentation, for the research and other information that was provided. Great. Does anybody have any questions?